Okay, thank you. Our next session is exploring the, I don't know, it's a kind of a time-worn question, I think, and that is, should local systems take bigger risks? And this is a big conversation, and I'm going to hand over to Lam, who's going to introduce the panel and explore the next 45 minutes of not an easy question.
Thank you very much for coming, everybody. It's lovely to have you along, and I'm really delighted to be here with such a wonderful panel of people. Very shortly, I think this light will disappear and I'll be able to see you. Yep, that's great. And so, as Roy said, we are trying to take on a big question today around something which, to me personally, is very important in the healthcare system. So before we start, I'd just like to introduce my fellow panelists. So. As a group of three, we've all had roles on different parts of the system, inside the system, and also in technology and other areas looking at as arm's length organisations. So wonderful guest today. I've got Katherine Ward here. Katherine, if you'd like to introduce yourself.
Yes, so I'm a veteran of healthcare. I've had 32 years in healthcare altogether, 15 inside the NHS, a management trainee, up to being a director of a PCG back in the day. 11 years with United Health Group, where I ended up running global business development for Optum, the services part of UHG. 6 years in an Israeli tech startup called Healthy.io, and I've just joined our Oxford Science Enterprises, which is a £1 billion venture fund based out of Oxford, working closely with the university to find cool bits of tech and spin them out into companies.
And is also legging it to a Billy Bragg concert this evening.
Yeah.
And I'd like to also bring along Malte Gerhold. After you, Malte.
Thank you very much, Liam, and good afternoon. Lovely to see you all. I'm Malte. I'm the Director of Innovation and Improvement at the Health Foundation. We're a charitable foundation supporting better health in the UK. I lead on our portfolio on innovation and improvement, which includes funding programs, insight and research, and also some big institutional investment with university and other public partners. I'm probably a bit of a jack of all trades when it comes to sectors. I worked in a startup before this. Done a bit of freelancing. I worked at the Centre of Government, including Regulation, Department of Health, and the private sector, and abroad before that as well. So I hopefully bring a bit of a dynamic from all those different sectors, like Liam and Katherine do.
And my name is Liam Cahill. I'll be leading the discussion for today. I work with the system to try and drive innovation and get some of the obstacles out of the way so we can improve how we innovate in the system. But I also work with tech companies on how to navigate some of the things that are still in the system that may affect their ability to work with the system around innovation. So, we will be having a few questions at the end, and so as you come up, if you have a bit of a think about questions, and hopefully we'll get a bit of time at the end. But I'd like to start with an opening gambit. So, in health and social care, the speed of innovation and improvement is being hugely outpaced by the growing scale of system challenges. We just need to look at the Health Foundation, for example, describing what we're facing as a polycrisis. And of course, by looking at the system, many of the statistics in terms of the increasing demand and the reducing supply are not going in the direction that we'd like. Secondly, we also have a situation where, particularly over the last 12 months, we have seen real evidence out there in society that we are tangibly entering the beginning of the digital industrial revolution. Just thinking about, for example, the last 12 months in AI and some of the things that we've seen very much tells us that there is huge room for innovation and that disruption and growth is absolutely going to grow. Finally, of course, we have the integration agenda. We have huge system changes, in the NHS. This is the first of its kind in a large public sector system. And whilst obviously there's a lot of narrative and cross-party support generally around the integration agenda and including internationally, we also don't necessarily have evidence that it will achieve all of the things that we're hoping it will, particularly within this fiscal environment. In times of great need, innovation often emerges and we move the shackles that get in our way and manage to step forward to address some of these challenges and do things that we didn't think we'd be able to do. We all need to think, for example, back to the global pandemic and the story that we tell about how we managed to really step up to the challenge. Yet, at the moment, as a system, it's arguable that we are getting more and more risk averse. And we're having more intervention, more obstacles that are coming in the way, whether this is politicians to NHS England to local systems, particularly those who are in financial measures, and also around local systems to place. As a result, For those of you who are in the health tech community, particularly those who are seeking investment, I don't need to tell you how low the confidence levels are around investment and viability of the UK system. So I'd like to take this gambit and ask, are you comfortable with the pace of innovation and risk that we're taking at the moment? And I will go to Katherine first.
No, I think is the straight and short answer. We all know the statement, I think, about the fact that it can take up to 17 years for evidence-based practice to translate from an idea, a concept, a piece of research into actual practice. And I think that is one of the challenges that we have in the system that we're working with at the moment. I think even when we see bold steps being taken, the actual pace of change that takes place behind them is glacial, to say the least. If you think about, for example, the big data platform that has just been announced as a new sort of stepping stone into better approaches to data and analytics for the NHS. Clearly, it's a controversial move. It's a contract that's drawn a lot of attention, but it's been months and months and months and months since we were expecting a kind of announcement, and that announcement, when it eventually arrives, is what everybody knew. The answer was, 18 months ago, 2 years ago. And so any benefit, and I mean there's arguments about the pros and cons of that process, but any benefit has essentially been postponed through a hugely political, protracted process of bureaucracy that has taken all of this time. I think another good example of where we're not capitalising on our potential as a health system is the amount of energy and resource that has been spent on redesigning, restructuring the ICBs at the moment. So, I was part of a health tech business that literally was, in absolute paralysis from probably December 2020 until July 2021, because CCGs, PCTs, whatever the commissioning entities are called, whatever three-letter acronym we have, were turning into ICBs. There wasn't anything to contract with for at least 8 months. You get to a position where finally established boundaries, there are defined organisations, and the first thing that then happens is another major reorganisation, which has led to absolute paralysis in decision-making. So it's just the pace is, whatever the intentions are, whatever the approach to trying to get stuff done, it's just being tripped up by large bureaucratic processes.
Yeah, and now everyone's playing wait and see for the next general election, which is in another 4 or 5 months, and now we're all waiting for the next piece of information that will tell us about the future. Malte, quite recently you stated through the Health Foundation that the NHS is strangling innovation. Clearly that suggests that you have a level of discomfort, but putting the question to you, where's this lie with you?
Thanks, Liam. I'd like to start with putting this idea of why we need innovation as sort of sharp relief. You mentioned the pressures around that. We did some projections earlier this year that showed that by 2040 we're going to have 1 in 5 living with a major illness in England alone. So that's 9 million people from 1 in 6 right now. So the demand that creates means that even the best possible efficiency productivity program we could even dream of over the next 15 years is not going to help us solve that problem. And I sort of emphasize this point because I just don't think it's sinking in. People sometimes say oh, we don't have the same burning platform as during COVID. And no, we do. It's just burning really slowly, but it's definitely on fire. And what it means is that we end up having conversations that are very specifically around bits of productivity measures, the next couple of years, so it looks like. And what we're not having is a conversation about what is the shift and change we need to see in the next 15 years and how is technology going to help us for that. So that's the sort of first point of really sharpening this point about the need for it and what it looks like. Sort of second one is that doesn't mean that all we focus on is the next 10 years or so. I think sort of to my mind there's 3 different perspectives to sort of put on this debate. One is, what do we already have and can utilize now that can make a difference, that can demonstrate a difference? And Liam, you referred to the fact that there is some technology out there now that's proven to work and that we can do something with. And I think we'll come back in the conversation about sort of how we can do that. The second one is to continue to invest in the infrastructure with a view towards what it looks like in 5 years' time and what we need for that. So the debate about electronic health records, the FDP, they're all great. What I don't see in this debate is anyone asking the question, what's the world going to look like in 5, never mind 10 years' time, and what's the piping that we need at that moment in time to actually make the most of it? Because when you get an American coming over who's had an EPR for 10 years, they will point out that actually all these things that we're doing at the moment are not going to be enough to make any use of future AI models and opportunities coming down the track. So what are we doing to think about that in terms of priority and infrastructure and scaffolding to build? And then the third one is that longer term view. How do we think around innovation and technology as generally transforming pathways for that? And the reason, while I've previously said that the NHS is at risk of squeezing innovation out of the NHS, is sort of twofold. One is because the short-termism blinds us to the bigger transformative effort that we need and what's the brain of it, and because the effort we need to put into the change capacity and transformation for it to actually implement it is also being lost. But we'll come back to that, I think.
Yeah, and we were due to have a fourth panelist who is a system digital leader, and you know, we had a conversation over dinner where we were violently agreeing about some of the areas that you could really make an impact in local services. And then at the end of the conversation, he said, we're in level 4 financial measures. Like, it's not going to get signed off by the regional team. It's too risky. We're not going to be able to do that because it doesn't release cash in the next financial year. So I can't put it across. And that was obviously a very frustrating point. So obviously the premise of this discussion today is around risk and taking enough risk. Like Katherine, I'll come back over to you. Where would you like to see more risk being taken and how?
So I think one of the biggest challenges in trying to get technology embedded and adding value to the NHS is around culture. So I think there is a lot of fear of failure amongst people who are on the ground trying to get things done inside the NHS. There's a strong sense that if something goes wrong, there's no benefit which you might see in the private sector around failing fast, around trying something, measuring it, seeing if it works, finding it doesn't, switching it off, switching or evaluating and changing something till it does give you the results that you're looking for. Instead, there's this huge challenge of, well, you know, we started the pilot, we better finish it, we'll keep going for 3 years. Well, that didn't necessarily make the impact that we thought it would, but if we stop, then that will be seen to be failure. Failure's not allowed. And I think that's a huge issue. I think the other issue is just there's a kind of massive chasm between national initiatives that are sometimes saying the right thing and trying to kind of persuade innovators to come into the NHS and find ways to help. There are endless accelerators and other sort of hubs and AHSNs and a lot of infrastructure built around trying to get you to do a pilot. Sometimes there are strands of funding that help you to get a kind of larger scale and to prove that out. Even if you get those little pilots running and established, there's really nothing in between that helps you then to get a sustainable mainstreaming of the technology you're trying to deliver. And I think that's one of the biggest challenges, that for companies, they just don't have enough runway to kind of keep on the road for long enough to get to the scale they need to actually make a viable difference. And the culture then is my other issue, that's just not there to support the level of change that's required to drive this change that we're talking about.
And all you've got to do is read BBC News over the last couple of days. You know, a high-profile story about a hospital that was described as toxic culture. You know, we've seen the story before. We don't need to go into the details of this. But somewhere in that hospital, there's an innovation program rolling where they're saying, bring your ideas, try something new. And I wonder culturally how they, you know, whether everyone feels that they can go and fail safely in that organisation, right? Like, you've got to ask that question. Or, you know, they've seen some tech solution they want to bring to the team to say, yeah, it's a bit of a risk, but it could have huge benefit that we can't quantify at this time. Like, where do you stand on risk, Malte?
So I was going to say, I'd like to see more risk-taking in terms of taking bigger bets and doubling down on seeing through a particular change. So I think it's related to what you were saying there, Katherine, about actually picking an area, a pathway, a disease, an issue, and not just starting with, here's all the ideas and here's all the trials and here's all the pilots, but setting it out from there all the way through to what does it look like to then actually spread this regionally, if not nationally. And a lot of the functions that we currently have, certainly the national level and sort of funding approaches, don't help us with that. I think that the implication of that, taking those bigger bets, is that you have to be narrower, right? We can't, it's great that we've got the life sciences mission, probably still too many, right? We have to sort of start somewhere. You can't work on all of them at the same time. You can't put that much money into all of them. So which ones are we going to pick? And that's a really big, risky bet to make for a minister.
Yeah.
Or for the NHS, because there will be someone lining up on any single issue that you're not working on. But I think unless we're willing to prioritize and sort of take that bet, we're not going to be able to see it through, and that's the sort of first risk. The second one around risk-taking I wanted to mention, which relates to the culture point, is what is the conversation that we're having both at a national level but also at a regional and local level to some extent about the benefit of the change but also the risks of the change that we're trying to achieve, and how we're preparing all of our communities for a change in how care and social care is being delivered, and indeed moving out of hospitals, etc. That means they trust that it's possible because it's very different and there's lots of issues around change. They see that it can benefit them even if they're part of particular minority groups or in sort of different areas where they've not seen a lot of benefit from anything the NHS has done for them sort of over time. And an environment where we will fail on something, right? There's lots of debates about data privacy and sort of health data. It's very important. I think the bigger issue is going to be the first person who looks at some app or uses ChatGPT and then does ChatGPT and then doesn't go to a hospital and dies because they got the wrong result. So how are we having a public conversation about these implications, because they are real, and it feels like we're not trying to touch them at any level.
Yeah.
And that's really risky because you have to admit vulnerability and that you can't resolve any of these things. But I think unless we have a way of having conversations about the possibilities of this, that we have in lots of other, everyone acknowledges that if you have nuclear energy, there's a risk of nuclear energy, right? If you drive a car, there's a risk that you crash a car. So why we're not willing to have this conversation also around aspects of healthcare, because it's really icky, but I think we need to have it.
And there's a real element of double standards around this as well, particularly with technology. And I've seen this time and time again, where you might have a piece of technology that has a 98 level degree of specificity, and they go, well, that's 2% risk. But if you look at a nurse at the end of a 16-hour shift or whatever length of shifts they're doing, or a GP on a Friday afternoon who's just been trawling through patients all day long, every day, there's also a high degree of risk there. And I think, in a lot of the work that I've been doing, it's, risk has been seen in a very specific way that we need to, remove all risk. And to me, I think we're on the verge of violent agreement around this, but this is a cultural element. And you've picked up on, NHS England. I remember it was about 6 months ago that NHS England paid, I can't remember the figure, but it was many, many millions. So their approach to culture was they wanted to get a PR agency in to promote their open listening approach. And to me, that's got red flags all over the place, because that's the last thing you want. It's not about PR, it's about how you act, right? So, look, I think we can know where this conversation's going, but when it comes to technology and it comes to taking a risk, and the things that aren't happening, where do you ascribe this happening? Is it technological? Is it skills? Is it people? Is it culture, of course? Where do the biggest problems lie around this?
I actually think the biggest problem is culture, and we'll come back to it. But I think there is a more fundamental issue too, particularly for organisations trying to scale technology in the NHS, and that is just this pathway that I described to you about how do you take something, have it tested and scaled appropriately, prove scale, and then actually get into a mechanism for ongoing sustainable funding to actually allow that to then add the value that it can bring to the NHS. And I lived through this experience with Healthy.io, where we were fortunate enough to be part of the Accelerated Access Collaborative, which was deliberately set up to take companies that had the proof of concept, that had the first level health economic evaluation, that had their all their GDPR signed off, that had all of their data integrity and kind of safety issues addressed, but needed to prove scale. And this was a sort of a 4-part process, and we were in the 4th cohort, which was all about proving scale. We took the technology to 850,000 NHS patients and showed that we could reach 55% of people who hadn't done a urine test in 12 months, who were at risk of chronic kidney disease. We engaged more than 1,200 GP practices individually, because we had to get a GDPR sign-off from every single practice. We invested a huge amount of resource to prove that point, got to the end of the program and then fell off a cliff, because all of that approach to, how do you actually then get something sustainably funded just hadn't been built, despite all of the statements about the fact that this was an important priority and it was going to happen. And the challenge there then is you have to just look to other markets rather than the NHS to come and prove out what you're doing, which is the biggest irony, that you come here because you believe in the single payer government system. You've got an ideal situation where you have 100% coverage in primary care, you have integrated electronic, you have full electronic medical records in primary care. There's just so many advantages to the system. But if you can't then see a pathway to making it happen, and even the regulatory environment, there's a big question about, well, should NICE play a role then in regulating technology from that point of view? NICE is used as a reason to not fund you if you haven't got it, but if you have got it, it's not used as a mechanism to enable funding. So it's just this sort of lack of a clear and transparent pathway that I think is one of the biggest problems.
Yeah, and actually, like some of these high profile, like Healthy's up there as one of the examples of, who should be entirely proliferated in the system. There's a handful of organisations who, like I sat down with NHS England myself and they were like, who's a slam dunk? Who could we go for? Who could we prove? And I was like, well, Healthy. And then I gave a number of other organisations. And they were like, oh, yeah, we're doing that. Nothing came of it. And there is a really big signal if organisations do all of this work, navigate all of the things that people don't, that you're not being told. There's no playbook on how to do this. You've got to work it all out, and it takes, individuals like you, Katherine, to know the system and the things that you're going to be asked and so on to get to that point. But if you get to that point and you've got everything there laid out and it doesn't proliferate, then that sends a real signal to the international community around how viable is the system and how, if they're not prepared to take a risk on the things that have been proven as not a risk and proven to have benefits, then, what now, really? So, Malte, any views on this?
So just on what you were saying, Katherine, there, in terms of the sort of fuller pathway, for me this sort of comes back to, can we more clearly prioritize which pathway we want to see through, because we can't do it with all of them. Because once you've made that decision, you can start thinking about, all right, what would a payment mechanism look like for, at-home urine testing for certain conditions, for example? How could we potentially create a marketplace? Nothing against Healthy, but it's, it's one company, there could be others. Like, do we want to create a marketplace? What would that look like? But often because we sort of think ourselves some of the way, and then we wait and see what happens, and then it's successful, and then we haven't thought the rest of the way, because we've sort of been trying to think that on 20 different pathways rather than three or four for that. I guess two other points that I think are so significantly undervalued, sort of within, certainly sort of at a national level, or sort of been eroded over some time. One is the idea that somehow change and transformation capacity will magically appear if only you've got the right type of leadership and the right idea. And it doesn't. It's a skill. These are people who've trained for many decades to be really good at change management and change processes. They're not the same as the tech company, and they're not the same as the clinician or the nurse or the other care staff, sort of for that. And while we've got a political debate about the NHS being sort of overmanaged, whereas in fact it's undermanaged, we've basically taken all of that change capacity out at all levels. It's the sort of first thing that falls. So if you have a good idea, then unless there is someone who's got enough energy and can corral it, it's not going to happen. And that sort of question of where, how do we, I've said this at a different panel, a different conference, something like, to what extent can we make implementation sexy enough again that people actually think this is worth doing? There's never going to be sexy on a doorstep for a politician, because that's waiting times and sort of access, not implementation. But it should be behind the scenes, sort of seeing it through. I think another element that is undervalued within this is to have a much more open and honest conversation with care staff and the public to some extent about what is it that you actually really want to see change and will make your life better as part of this. And the point is not that we then run exactly after whatever we get told, but the point is that we have a conversation that starts from what people actually find really annoying. So one of our partner institutes from the Health Foundation, the Health Improvement Studies Institute in Cambridge, they've been doing a study with patients and GPs about what the top issues are, operational issues are that make their life really, really difficult. And the things in the top three are not about shared care record and 10-minute consultations, as we'd sort of expect, but it's referral letters. Because GPs find it annoying when these patients come back and say, where's my referral letter? And the GP says, I don't know, because it's gone somewhere, or it's come, you know, that. So the point is not that the next thing we solve in primary care is referral letters. The point is that we then have, if we have a conversation again with the GP about some funky stuff that we're going to do, let's at least acknowledge, you know, where that's sort of coming from. And I think it's similar with the public about what they're sort of telling us, always going back to having that debate in the starting point, what we're being told. And again, I think that's undervalued in this debate and makes it harder for us to take risk because we don't acknowledge it from the outset, or even say, look, we're not going to address that, and there's a good reason for it, rather than sort of, you know,
and let's
putting it on the carpet.
A second to remark on the fact that we're talking about letters. Sorry.
Like, you know, drawing this into the ICB level, because, like, you know, your point around a real discussion really resonated with me, right? Because, like, I go to a lot of these conferences and I hear a lot of people doing the everything is awesome dance, you know, and, like, I look at the system and I think everything's not awesome. And I think, you know, with these, I suppose, sensitivities in the connections between different parts of the system, it feels like it's very difficult to be able to have that conversation. And recently, I heard a senior leader from an ICB talking about how integration will solve all of the problems. It will make everything better. We've just got to deliver the vision. And I'm sitting there thinking, really? Where does digital sit in this? Like, are we just going to integrate our way through a digital industrial revolution and then somewhere technology will play a role? Like, how do we, you know, we obviously need to have some really big discussions in the system, with the stakeholders of the system, with the tech companies who are supposed to be coming to the system, right? Because, you know, we say the UK is a really fantastic, viable, attractive place to come, and then there's some nasty surprises that come. So, like, I suppose, you know, just drawing this to an ICB level, like, what conversation should what should the ICB be saying and doing in order to kind of give a greater dose of reality to the stakeholders who need to participate with it and engage with it? Like, either of you are welcome to jump in first if you...
I think one of the things that would be really helpful would be the ICBs to be a bit clearer about what they actually want, need, desire, what their gaps are. I think there's a lot of technology companies turning up on their doorstep and saying, here's my solution, does it fit your problem, rather than necessarily the starting place being, okay, this is what I've got to solve for, who can help me with this challenge? Yeah. And that level of dialogue isn't terribly present anywhere. I think there's a tension here between the local and the national, and I've already kind of commented on the challenge it presents for companies to have to go even 41 times, which was clearly better than 225 or however many CCGs we had, but it's still a lot of conversations to have. And it's then amplified by the fact you have to get a GDPR sign-off in every single different ICB, and it's a different decision-making process in each one, and actually a different decision in some of them, even when they're coterminous and sort of neighbours, you know, and some of them it takes 2 weeks and some of them it takes 18 months. So there's all of that kind of practical stuff as well. But I think being more clear about what are the top 3 issues that I'm needing to address and what are the potential digital approaches to that would be extremely helpful and would stop a lot of people, and I mean them being clear about everybody else, just go away for now because we can't deal with any more than this, would actually be quite helpful.
Yeah, I totally
agree. A fast no, if you like.
Yeah, I totally agree. I raised this point with the NIA actually, and they said that they're planning to kind of do this as a bit of a framework. I've yet to see it, but like that's been proposed because, like, you know, like Stottle's downstairs, where you've got to like go and find like, you know, like buying indicators and try and read between the lines on what they've got. Like, ideally, there should just be somewhere where they say these are the 5 things we're looking for and the 5 things we're commissioning, so the right companies can come to them. The others don't have to waste their time, you know, for a bit of matchmaking. ICBs, what would you be advocating?
Yeah, so I would have made the point around demand signaling as well, and sort of clear prioritization. I guess to complement that, I think there's also something about, you know, being very confident in the difference that each ICB is facing in their situation, the sort of context within that. So there might be some ICBs that have 3 teaching hospitals and a couple of university research centers, and there's others who've got 1 hospital and no national research centers. And actually, again, that sort of honesty of the conversation and what that means for their prioritization, because it doesn't mean that they can't do very, very exciting things. They might just be doing very, very exciting things on, you know, primary care in rural communities, for example, or coastal towns, rather than some fancy things in cancer centers, and that's perfectly okay. And I think going back to your point around sort of national and regional sort of tension, sometimes we seem to sort of think that we've got these 42 and they all have to do the same thing. And unless it's distributed 42 times, it's somehow not okay. And I think it is okay because the local population would sort of demand that as part of that. The second and separate point I'd make around this is that sort of for ICBs, I think it's sort of like real clarity about how at a regional level, and this is very difficult, so I have a lot of empathy, what is the model for making change and transformation happen in that particular regional patch? Because it goes back to what is their existing local context, right? In there's some really dominant big hospital providers that have a fair amount of capacity, or maybe it's even a collaborative between several providers, they can probably do quite a lot of things for you. So that might be the way you go. You actually use that change capacity and you drag it out also into sort of work with this community. In other areas, you might have none of this, and you have to ask, okay, where is that capacity coming from? Do we actually have to build some of that up? Incredibly difficult in terms of sort of funding, but if it's not there, like, how is that going to happen? So that clarity of, so an ICB, if we want to make any change at this level, what does it look like for us, and where's that capacity coming from? There's of course the health innovation networks, formerly AHSN, sort of out there, but they work across several ICBs in many cases. They don't have a lot of capacity for change and transformation themselves, so they are part of the regional puzzle for an ICB to say, what does this look like sort of for us? And then on that sort of spread point, I think there are one or two examples now where there are initiatives of people thinking about what does this look like if we're trying to do this together, particularly what's happening in the north of England. I think it's very interesting how some of the ICBs that are trying to work together, including with their health innovation network, so to do things once rather than at least 3 times, which is a sort of start. But actually the initiatives we have around spread and adoption across organizations is still very minimal what's out there. There's the Insights program for hospital trusts. There's a new acceleration pathway in Scotland called the ANIA pathway, which is quite interesting in Scotland. It's very different in terms of its 14 health boards, sort of how it's set up. But actually we could do with more initiatives like that don't have to be national, super complicated. It's fine if it's just sort of 3 ICBs, or maybe even just 2. Let's learn what works in adoption and spread across more than one patch, and then think about how we do that more widely.
Because I mean, that is a massive issue, that the randomized control trial required in my hospital is still often what you get, even if you say, we've done it here, here's the evidence, here's the case study, you can call up that CEO and hear about how well it went for them. There's still this idea that unless you've proven it in my geography, then we can't just take someone else's word for it.
Yeah, and like, how much more can you do in order to convince them on that? Like, there does need to be a level where we say, this is an acceptable amount. And I've been sort of writing, commenting recently around endorsement and the fact that NHS organisations seem to be very hesitant to actually endorse tech companies because they feel they're doing something wrong, and the absolute absence of guidance around this, and from a national level around, like, what is enough for you to feel confident, where, because ultimately if we go back to the point of risk, what we're describing here is a number of organisations who are embedding their own self-perception of risk, and maybe this is too risky even though it's been done in 5 other hospitals. But it shouldn't be that way. It shouldn't be risky. I'm just going to give the audience a notice that I'm going to come to you for questions in a moment, any pressing questions that you've got. But I'm going to do a quick fire round, right? And this is not the kind of question you do as a quick fire round, but national. What would you like to see national? Like, what can help stop this nationally? Like, for me, I read Patricia Hewitt's recommendations, 3-year investment model. There was so much sense in this, and I thought a lot of this is never going to happen. Like, the system's just not going to do this really. But what about for you?
I think the NHS, in my experience of 32 years, either inside it or trying to work with it, the most important thing is the mood music. And if the mood music can be set that says it is permissible, it is acceptable, it is encouraged, you need to be using technology, those risks that you take within the parameter that we have to be within for publicly accountable funding, go for it, do it. And we want to see lots of examples of what's happening. And then we are prepared to then encourage people to actually take learning from each other rather than everybody having to do their own randomized control trial and actually take that risk. So I think the national systems have a large part to play in setting that mood music to allow then the level of local accountability to take place.
Yeah, and we managed to do the vanguards and the test beds, and that was taking a risk in the systems. Like, why is there no technological equivalent to be able to do that, to help people feel that they're not going to get told off by the national bodies? Malte?
And they didn't have a lot of implementation support beyond the initial, sort of period. I think that, I know what you're going to say, Liam, so I'm not going to steal that. But so for me, it is that, and it goes back to what you said around hope. And it's the permissiveness, but also I think we need to pick one or two areas and we need to demonstrate that we can change the pathways. Right? Because what we have at the moment, and maybe that is kidney disease, maybe that's dermatology, maybe it's something else, but generally seeing how we can sort of shift and change that. Because things like community diagnostic centers, they're great by themselves. They do not change any pathway, right? It just means someone goes somewhere else and then they go back to outpatients. A pathway change would mean that they actually have that whole experience in the community around a community diagnostic center that does lots of other things that they're possibly not set up for right now. Virtual wards are not a pathway change by themselves. They're just a way of, moving a few people from the acute outside the acute, which is great, but it's only a part of a wider pathway on various conditions where we could actually think about it completely in the community and sort of outside. So I think picking one or two, supporting and funding ultimately the transformation for it to show that it's actually possible. Because I think if we don't show it on one or two things, my worry is that no one's going to believe us around the permissibility.
Yeah, and I run experiments where you need the senior leader, the people at the top, to be able to say, we want you to take a risk. It's okay to make mistakes if we can learn from them. If there's a system, but instead we're spending money on PR agencies. Like, there's a lot that we could do nationally to be able to say, let's take a risk, let's try something, let's step up to the challenge. The challenge is huge, let's step up to it. And we want people to nobly fail in order to improve and save the system, dare I say. I gave you notice. I hope we have a couple of good questions. Mr. Lilly has the roving mic. Who has a? Oh, two.
Okay, ladies first. Here we go.
Thanks very much. Hi. We fall into the innovator trying to get into the NHS camp. Have an established D2C business whilst also trying to check all the boxes that Katherine talked about, the GDPRs and the clinical safety. Thank you for all of your input and everything else that I've heard over the last couple of days, but are there any actual success stories? Like, has anybody actually done it? And if they have, are there lessons that we can take from that? Is there any common thread, or is it random?
Wendy, are you not feeling positive and enthusiastic from our discussion? I can't. You must have been hearing a different discussion to what we were talking about. I thought it was full of.
Let's find out. What is your product? What are you trying to introduce?
Our product is Mutu System, so it's perinatal pelvic health. So I hosted a panel yesterday about the journey for perinatal pelvic health and women's health issues. And what we're just hearing over and over again is this kind of, there's a problem here and there's a problem here. And even when you do check all the boxes, it doesn't necessarily happen.
There are 8,000 GP practices with 8,000 front doors. There are 200 hospitals with 200 front doors. That's your problem. Anyway, he's the expert. He's going to tell you, Lam is going to tell you how to do it. Roll on the drums, boom.
Malte and Katherine, any thoughts?
I mean, I think there are successes in different dimensions to the answer to your question. I mean, Healthy IO still gets held up as the flagship of something that's been a success. 850,000 patients being able to test at home, reaching people who weren't otherwise testing is a success. The fact that it isn't mainstreamed and isn't streamlined, maybe that's the next step, and maybe in a few years' time I'll be able to come back and tell you that it is. Sleepio had an amazing success at getting through the NICE process, so they've done really well at being the first digital company to be evaluated through NICE. Unfortunately, to my previous point, there isn't a commercial pathway that follows on from that to enable them to actually get commercially adopted. But, so I think ultimately the answer is not yet, but there are a lot of people forging a path in different ways. Yeah, exactly.
Don't you think it's about trying, I think you touched on it earlier, it's about trying to figure out what it is we want in the NHS. I mean, we've had some very interesting discussions earlier in the day with the ICBs. Now, they're a very fertile area for all the people who come to conferences like this, because they've been born and they got kind of new things they should be doing and could be doing, but they got no money and most of them don't have an IT strategy. They don't know what it is they're trying to do. I mean, pelvic floor is a hugely important part of female health. It's a big cost center. It's a problem for a lot of women, and really it's left to a few clinics that somehow work out there, and it's not connected with any of the sort of zizzy stuff that we're seeing here today. But do we want that? Well, I mean, I would imagine the patients do, but do we? Where is that in the innovation agenda for change?
I don't know is the honest answer.
Well, if you take that as, that's a very niche product in what I know to be an extremely important area where we spend a lot of money, and it's a big problem for a lot of women. How does that get up the agenda?
So 2 points, I guess. One is it goes back to the need for that regional conversation and to some extent local conversation to really understand what is the factor that we can do, like what we want to do for local populations. That means prioritizing, but that'll also mean a lot of losers, right? And it might just be that a lot of the NHS say, yes, it's really good, but it's not part of our priorities. And to some extent, objectively, that is the right thing to do, which is not a reflection at all on what you guys are doing. But I think the sort of the flip side of better prioritization and seeing it through is that we're going to do less things better over time, and then sort of broaden it out. So that's sort of one answer. Back on your question, a bit of sort of how success is defined. I'm more optimistic about this. There's quite a lot of stuff that's happening in the NHS is great. Not all of it has been scaled to sort of success. And then also the most successful things are probably not where one company has seen it through. It's where a marketplace has been created. So if you take teleconsultations, now we can say COVID, etc., that is now standard, and there's a marketplace for it. So that's a success.
Okay, let's move on to our next question, which is next door.
Thank you very much. So I will say despite, thank you. Despite risk aversion, culture, funding and reimbursement challenges, governance barriers, leadership, politics, headspace and change fatigue, and the investor appetite out there, despite all of that, what are the reasons that you guys would suggest for health innovators in the UK to be optimistic?
That's a good question to finish on, Mr. Chairman.
Thank you.
Reasons to be cheerful.
I sat down with a tech company earlier and was talking about all of the difficulties. And the reality is, because we should, and I know that this probably isn't great when you're talking to investors, but we have to do this. The economic model, societal model, means that there might be a large number of eggs that get smashed up on the wall as we try to get through this. But we are patients too. Like, we are the ones that receive this, our families, and we have to try. Now, that doesn't maybe mean that we don't have to go to a different economy to do that. I don't know. But the fact is because we need it, and it's a noble endeavour, and we actually have to, we can't expect the NHS to take a risk if we can't take a risk, and then to see ourselves as being safe to fail. If you've got anything else you'd like to add.
I would just amplify Malte's point from before, and he said it's not burning like it was in COVID, but it's still on fire. I think it's burning worse than COVID, because at least in COVID we had that sense of urgency, and now we're just in probably a worse situation with all the backlog and all of the pent-up demand and the incoming political change that will undoubtedly paralyze us again for at least 12 months. That's why, because it's burning.
What they said.
So if you're coming here hoping for the answers on how all of this would be solved, I don't think that's what we can give you at the moment.
Well, stay for the next session.
Fantastic. That's the flip side of it. But, what I'd say is I think the points that Katherine and Malte have put aside absolutely resonates with what I'm seeing at the moment. And at the very least, I think it's really important that we at least have a conversation about what the reality is, because I don't think we're hearing this from other areas. So whilst there may not be a huge number of tangible takeaways on how your organisation can succeed, this at least hopefully helps you to have the intelligence to make a decision.
The entrepreneurial innovators, the NHS innovators, they've raised £830 million on the markets to get people to invest in their innovations. So there's an appetite in the markets, but it's just very difficult to find the right front door. Listen, this was a great, can we say thank you? It was a really interesting session.
Thank you very much.
Just flew by. Thank you so much.